Nasotracheal intubation involves passing the endotracheal tube through the nares into the nasopharynx and then through the larynx into the trachea. It is an essential skill for anesthetists and emergency medicine doctors. Performing nasotracheal intubation requires the knowledge of anatomy of nasal vestibules, nasopharynx, oropharynx, and larynx. Nasotracheal intubation may be done either blind or guided by laryngoscope with or without a Magel's forceps. When done blind, it could be either awake or asleep under anesthesia. Here, we are doing nasotracheal intubation under general anesthesia using a laryngoscope and Magel's forceps. Apart from routine preparation of airway trolley for intubation, we also need Otrivin drops, that is the oxymetazoline hydrochloride nasal drops, which is a vasoconstrictor and reduces the associated mucosal bleeding. Lignocaine jelly to lubricate the nasal passage to allow smooth passage of the endotracheal tube and also to lubricate the endotracheal tube, especially the endotracheal tube cuff. A regular endotracheal tube could be used, either a PVC tube, an armor tube, red rubber, or a south or a north pole tube, and of course the laryngoscope and the Magel's forceps to guide. Our patient is under general anesthesia in supine position with head in neutral position. For nasotracheal intubation, check the size of the nares of the patient prior to intubation. This helps us in deciding the endotracheal tube size. Usually the same size as for oral intubation or one size smaller endotracheal tube is good enough. You can use a lubricated soft nasopharyngeal airway to lubricate or widen the nasal passage of choice before inserting the endotracheal tube. In this patient, we chose the right nare for endotracheal tube and passed a nasogastric tube to the left nare. We then used the laryngoscope blade of the video laryngoscope to visualize the larynx, and with the help of a Magel's forceps, we guided the nasogastric tube into the esophageal opening. Now, introduce the endotracheal tube in the chosen nare and gently follow the natural curvature of the airway, first parallel to the hard palate and then downwards into the pharynx. In case of any resistance, gently rotate the tube while moving forwards and backwards and downwards. Forward the endotracheal tube firmly without any excessive force. Now visualize the glottis and gently forward the endotracheal tube into the glottic opening till the cuff is beyond the vocal cords and the black line of the endotracheal tube is at the level of vocal cords. Sometimes you may have to flex the head a bit or move the head to one side to facilitate this. If the endotracheal tube is failing to enter the glottis and is advancing towards the esophagus, in that case use a Magel's forceps to hold the endotracheal tube proximal to the endotracheal tube cuff and guide the endotracheal tip into the glottis. You can also hold the endotracheal tube distal at the tip of the endotracheal tube to lift it and introduce it into the glottis opening, but avoid holding the cuff with the Magel's forceps as it may damage the cuff and you may get a leak later. Now, inflate the cuff and attach the ventilatory circuit. Fix the nasal tube at the nose. The distance traveled by the endotracheal tube through the nose is more than that of an oral tube, so it would be around 24 to 26 mark at the nares. Wipe off all the jelly around the nares before fixing the endotracheal tube with sticky tapes. Fix the endotracheal tube and the rise tubes with separate tapes. Confirm the tracheal placement of the endotracheal tube by the EtCO2 waveform. Confirm the vitals and also auscultate the chest to confirm bilateral breath sounds. Advantages of nasal intubation are: it is comfortable and better tolerated by the patient for prolonged intubation in the postoperative period. It is suitable for oral surgeries. There is less chances of kinking of the endotracheal tube when in the nose. Accidental extubation is unlikely with nasal endotracheal tube. And it also facilitates swallowing of secretions, saliva and sips of water in a patient with nasal intubation in an ICU. The disadvantages of nasal intubation are the likelihood of trauma to nasal mucosa and turbinates while intubation, risk of sinusitis, difficulty in endotracheal tube suction, and risk of pharyngeal wall tear and adenoidectomy during intubation. Thank you.